let's go ahead and start. Welcome, everyone, to the next in our seminar series. I don't know the number specifically. Today, we're hosting one of our colleagues from the Department of Internal Medicine, an associate professor there, Dr. Ingrid Binswanger. Ingrid, as you'll learn more about her work in just a moment on substance use and particularly prescription drug overdose. But just to give you a little bit of background, I mean, she's trained in internal medicine, her medical training at UC Berkeley and her residency at UC San Francisco, and then MPH from University of Washington, Seattle, while she was also enrolled in the Robert Wood Johnson Clinical Scholars Program. In addition to her clinical responsibilities and research responsibilities here, she heads up the primary care fellowship program, and if you're interested in learning more about that, talk to her afterwards. She's got a lot of interesting material to present today, and we'll go through it and then take questions at the end. So welcome, everyone, and thanks, Ingrid.
Thanks. So this is my... Okay. Oh, it's this one. It's that one. Okay, great. Okay, so I'm going to start, well, let's see. Do I know how to use this? Okay, well, that doesn't work. That's all right. I'll use this. Okay, so I'm going to start just by telling you a little bit. I'm going to start with a case today, and then I'm going to talk about some epidemiology around overdose and also some preventive strategies that are emergent. And my perspective is somewhat colored by the fact that I work in primary care. So I have a primary care clinic where I prescribe opiates for pain to patients, and I have patients who do sometimes have gotten in trouble with those opiates, but also who've majorly benefited from opiates as well. And I have to counsel patients about these. And I also work in substance abuse services with ARTS, Addiction Research and Treatment Services, at Potomac Street Center, where we actually treat patients for opioid dependence. And we've seen increasing numbers of young people addicted to opiates and also patients who've experienced overdose at that clinic. So I have kind of both the substance abuse and the pain perspective based on both those practices. I will be talking about one non-FDA approved device for administration of Naloxone, which is an opiate antidote. So I just thought I'd mention that disclosure. And then one other thing is I do have some preliminary data from various studies that I'm working on in here. So that stuff isn't really ready for a wide citation, and there won't be a citation at the bottom, but it's new data. So I thought you might be interested. So the objectives are really to give a case presentation. I'm going to talk about trends in opioid overdose and then describe some high-risk settings and times for overdose, as well as emerging approaches to prevention, some of which are kind of just new ideas about what we might be able to do about this problem. So the case is really one that I heard from one of my colleagues in primary care. And this is a 56-year-old woman with diabetes, type 2, who presented to her primary care doctor for routine follow-up of her diabetes. She has a past medical history of chronic low back pain, diabetes, hypertension, and hyperlipidemia, which is pretty common in our practices. This is probably the most common combination of problems we see. She's on oxycodone-acetaminophen combination, which is also known as Percocet. She takes 1 to 2 tablets every 6 hours, and she's been on these for the last 8 years for her low back pain. She gets about 120 tablets a month. And she hasn't had any problems with these medications. She's on 6 other medications for her chronic medical problems. So the patient came in to see her PCP one day and brought her blood glucose log, where she had tracked her blood sugars very religiously. She had 4 pages of glucose logs, and in the comments section, she wrote, "My daughter died today on one of the days." And short of that, she didn't mention anything to her primary care doctor about what had happened. So her primary care doctor looked through all these and suddenly saw that note and was like, "Oh my goodness, what happened?" So her daughter was 35 years old. She was found by her mother in her bed unresponsive. The paramedics were called, but resuscitation failed. And the coroner report indicated oxycodone and tricyclic antidepressants as contributors to her death. The cause of death was pharmaceutical poisoning, undetermined intent. And the patient now cares for her 13-year-old grandchild. So the patient at one of the subsequent visits brought in the coroner report because she really couldn't understand what it meant. She didn't know what anything on it meant, basically. And it revealed that, so basically, it revealed the substances, which included one of the substances that Mom had been prescribed. And she told her primary care doctor, yes, I used to share this medication with my daughter. I have for years. Whenever she has pain, she can have, she uses some. And that's not what happened just prior to the death, but there was a comfortable sharing of the medications within the house. And she really didn't know that there was a risk to sharing these medications. That was just not even something that she was aware of. She'd never been counseled on that. It wasn't part of her, her repertoire of knowledge. I'm not even sure that she would have necessarily known that that medication was more dangerous than any of the other medications she was on. So first of all, for those of you who are not clinicians, what are opioids? Well, opioids are, generally derived from the poppy. There's various kinds. Some of the common names that we hear a lot about are Percocet, which is oxycodone in short-acting form, and it's combined with acetaminophen, Tylenol. And then Oxycontin, which is the long-acting. Most of these are Schedule II. Heroin is also an opioid, but it's Schedule I, so there's no medical use by the DEA. And then Vicodin, or hydrocodone that's in Vicodin, is going to soon be Schedule II, but it's still Schedule III. So in about 2001, there was a lot of efforts to try to improve how we manage pain, because our quality of care for pain is not great in how we deliver health care. And so the Joint Commission, or JCO, started making pain a big issue, a priority in their accreditation efforts for hospitals and healthcare facilities. And one of the things that they insisted on is screening for pain. So there was a lot more attention to pain, self-reported pain, listening to the patients, respecting what they had to say about pain, and also a lot of liberalization of how we used opioids in practice. So basically in the last decade, we've seen a very large increase in prescribing of opioids for non-cancer pain. Chronic opioid therapy, which we also call COT, commonly abbreviated, non-medical opioid use, which I'll talk about in a moment, and then a lot of complications of opioid use. And all of these have been documented. Drug treatment admissions have gone up, emergency visits have gone up, hospitalizations and deaths. So this is some local data from Denver Health from my colleague Laura Hurley there, who basically took a look at prescribing practices at Denver Health over time and saw a tremendous increase in the number of opioid fills from 2001 to 2010. That's those black bars up there. And then the blue line up there is the percent of all pharmacy fills. So all prescription fills went up at Denver Health. So what about as a proportion of total fills? And that also increased dramatically over that same time period. So some of these medications get diverted and people use them non-medically. Now, people who have prescriptions that are legitimate can also use non-medically. Non-medical use basically means use without a prescription or for the feeling it caused. So you can use your medical prescription non-medically, or you can divert it and somebody else can use it non-medically without a prescription. The average age of initiation of non-medical use, based on the National Survey on Drug Use and Health, is 21 now. And among people who report past year non-medical use of pharmaceutical opioids, 55% report getting it from a friend or a family member for free. And I think this is really different than heroin or cocaine or other drugs, which are commonly bought by dealers. This indicates that there's a lot of sharing and giving away, et cetera, of these medications, and that's a different problem than we see with other illicit drug use. And 17% got it from one doctor, so fewer just get it, consistently from a doctor, but a good proportion still clearly are non-medically using the pills and getting it from their doctors. Colorado, unfortunately, is number 2 in the rate of non-medical opioid use in the last 12 months, second only to Oregon. This is the latest data from the National Survey on Drug Use and Health. Colorado, for people 12 and older, 6% report 12-month use of non-medical opioids in Colorado, based on this representative survey. For 12 to 17-year-olds, it's 7.4%. For 18 to 25-year-olds, that's the peak. It's 14%, and above that, it's 4.4%. These are all elevated compared to national rates. So we have a particular problem with this in Colorado. So this is also reflected in survey data of college students. So 1/3 of college students report having used pain medicines without a prescription in the last year. Commonly, they report farming, and farming is the term for basically stealing your parents' medicines out of their medicine cabinets. I use the term sharing also to address this other problem, which I think is important, about parents sharing and other family members sharing medications with people for whom they're not prescribed. But that's not a commonly used term. I just made that up. So we've also seen a fair amount of transition to heroin use, and this is increasingly being reported and also reflected in some of the overdose numbers. So unfortunately, I just looked at this last night. 620,000 people nationally reported past year heroin use in 2011 compared to 373,000 in 2007. So that's a pretty dramatic increase in heroin use. Pharmaceutical opioids are much more expensive than heroin. And some pharmaceutical opioid users definitely transition from pharmaceutical opioids to heroin use, either when they lose their supply because their doctors say won't prescribe it anymore, or when it becomes too expensive for them to support a pharmaceutical opioid habit, which is over $1,000 a month frequently. A little terminology, because this terminology is used in so many different ways, and it gets very confusing to compare numbers and rates. So I just thought I'd clarify. Poisoning is the event. It can happen from pharmaceutical opioids, heroin, cocaine, any other substance. But it's a broad term used for multiple substances. And intent can either be intentional, so that would be suicide or homicide, unintentional, or otherwise known as accidental, or undetermined. And overdose is used in many different ways in the literature. I generally use it to mean unintentional or undetermined, but some people mean it to use any intent, but also just a poisoning. So it's used in different ways. So you'll hear me use different terms, and it depends on how it was used in the literature for those specific phenomena. So this is a study that was done by one of our fellows in the primary care research program, and Susan Calcaterra, and basically this is looking at Centers for Disease Control data from CDC Wonder and looking at trends by substance from 1999 to 2009. And basically what you see here is the death rates from pharmaceutical opioids have really dramatically increased. And the death rate from cocaine, which is the blue line, have come down, which is great. But heroin death rates that were really very steady in red for a long time have started to show an uptick. And that's what we're starting to get concerned about, these opioid users transitioning to heroin. And then psychostimulant deaths went up, and then they came down a little bit. That's methamphetamine or Adderall or, pill use from stimulants. Polypharmacy is pretty common in opioid-related deaths, although it's not necessarily the majority of deaths. The most common additional drugs in opioid-related deaths are antidepressants. That's pharmaceutical drugs, I mean. Other common substances include benzodiazepines, cocaine, and alcohol. This is some data from Colorado also showing the increase in mortality rates from poisonings, actually this unintentional opioid poisonings by gender. And it's more common in men than women. And we do see that in 2010 it looks like there was a decrease. There was a pretty dramatic increase and then somewhat of a decrease in 2010. And I don't know if that trend is going to continue or not. But this is the latest data from the Colorado Department of Public Health. They just issued a very nice report on this problem that this data comes from. In terms of race in Colorado, so I'm focusing here on Colorado, it does appear that the death rate is a little higher in African Americans than it is in whites. And after African Americans, it's American Indians and Native Alaskans, then white non-Hispanic, white Hispanic, and very small rates in Asian Americans. So what are some of the known risk groups for opioid poisoning? This is a little difficult because most of the data that have been collected on risk factors for, or risk groups for opioid poisoning actually comes from coroner's reports and death reporting. So we don't have true risk factors, so we don't know if certain groups are at higher risk after exposure to pharmaceutical opioids because we don't have the exposure data. So these are not true kind of risk factors that I can describe. But there has been a little bit of work done in the VA and at Group Health in Washington State looking at dose, and it does appear in large health plans that increasing dose, especially over 200 milligrams of morphine equivalents per day, is associated with a significantly increased risk of death. And in those data as well, they showed psychiatric disorders and substance use disorders are also associated with increased risk of death. We also know that there's some increase with multiple substances, as I mentioned. And then in reviews of death records in West Virginia, there was clearly an association with doctor shopping. So people who visited 5 or more doctors in the last, I think it was 6 or 12 months, clearly were a special risk group among people who had died. So the other risk time, and this is something I've been working on for longer than the pharmaceutical opioid issues particularly, are really after release from our transition. So these are after release from jail or prison, after detox, short-term detox, and this is kind of the tragedy of this scenario is that people face an increased risk after detox, and also after hospitalization among people who already have opioid dependence. So this is data from a large data set that we have in Washington State where we linked records from all releases from all the Washington State Departments of Corrections to the National Death Index. And we followed people in a retrospective cohort study from 1999 to 2009. We had 76,000 people in this database, and we had 2,462 deaths among former prison inmates, with a mortality rate of 737 per 100,000, which is about 3.5 times the general population rate for the same age, gender, and race. So former inmates are at high risk for dying. And then among the causes of death, injury deaths were the most common cause of death. And that was led by unintentional poisoning deaths, with a mortality rate of 167 per 100,000 person years. And to put this into context, these former inmates are generally young, so the mean age is about 33 at release, and the mean age of death is about 43. So it's a pretty young group of people. Motor vehicle crashes also were high at 55 per 100,000 person years. And since we have an injury prevention audience, I thought I'd also share that the other 2 injury deaths were homicides and suicides, which were among the leading causes of death.
Sorry.
Yeah.
Is there a level of subjectivity by someone finding unintentional poison?
Yes.
Especially if the person is deceased.
So there's a number of issues with the coding of these deaths and how they're reported on the death certificate, either absent codes for substances because there was no autopsy, or some issues which toxicologists would know better than I do about the metabolism of heroin and into morphine, and there's a lot of complications and a lot of subjectivity. So there are, and certainly because more of the population is on pharmaceutical opioids generally, you're going to see more in their blood when people die. So there are a lot of complexities about that. So this is also very recent data that we have on the time trends after release from prison in terms of death. So prison essentially represents a period of forced abstinence. There is some access to drugs in prison, but not as much as you would get on the street. And what we found is in the first week after release from prison, a very high risk of death, substantially higher than subsequent periods. And this is particularly for unintentional poisonings. So this flux in dosing, loss of tolerance, followed by exposure is really key to part of this problem. So in terms of the substances involved, this was also very interesting to me. In our prior study, cocaine was involved in a lot of the overdose deaths. And in this study, we found opioids predominated with a higher death rate. And actually within that, it was not heroin, it was pharmaceutical opioids. So even in this population that represents a lot more heroin use of former prison inmates, we see a problem with pharmaceutical opioids. So this slide also illustrates some of my reason that I focus on transitions, not just static risk factors for overdose, but on transitions of dosing. This is a very interesting study that was published in BMJ in 2010 from the UK, where they followed over 5,000 people who were on opioid substitution treatment with either Suboxone or methadone. And what they found is the first 2 weeks on treatment was associated with a higher risk of death than subsequent 2-week periods. And that's these yellow, those are light blue bars. On treatment, the risk of death was low, lower than at any other time, including off treatment. So treatment works. It reduces the risk of death. But the first few weeks, induction into opioid replacement therapy is a risky time. And that's partly because the dosing of long-acting opiates is complicated and it takes time to reach to steady state. And so sometimes practitioners are not savvy in the way that they dose it properly. It's also because people may still be using street drugs or pharmaceutical opiates at that time on top of the methadone or the other long-acting that they're receiving, and they're also at risk during that vulnerable time of first induction. So induction is a bit risky. The rest of the time on treatment is good. Then you get off of treatment for whatever reason, and the risk is very high of death, substantially higher than on treatment. And then that comes down to a baseline. So we see similar patterns, and this has also been shown recently among drug-dependent individuals after hospitalization for medical conditions. So these time trends are very dramatic, and I think they're going to be important in dealing with this epidemic. So this is one more slide to say treatment does work. The longer you're in treatment, this is the probability of treatment, that treatment reduces average mortality. The longer you're in treatment, the lower your risk of death. So this is also very compelling observational data about the benefits of methadone if you didn't already believe that it had an impact. So in summary for this section, transitions are high risk. For opioid-dependent individuals, treatment with opioid substitution therapy does reduce mortality, but caution is indicated after periods of enforced abstinence, such as jail, detox, hospitalization, if they're abstinent then. And then caution is also indicated with changes in dosing, including treatment induction and discontinuation. Okay, so let's see. I've now summarized some of the epi that's involved in this phenomena, and now I'm going to talk a little bit about possible strategies. And these are strategies that are both been discussed, that either I made up or that have been discussed in the literature or among my colleagues, or that I know about from harm reduction programs or other people that are really working on the ground level in the community to try to address this problem. So first of all, I think there's a lot of efforts being done, especially out of group health in Washington, to educate physicians on safer opioid prescribing and risk of overdose. They've actually focused predominantly on the safer opioid prescribing, more appropriate selection of patients, monitoring of patients, and just overall decreasing how many pills we give out. So that's one effort that's been made. Less has been done on educating physicians about the risk of overdose. We were taught for a long time that these medications are relatively safe, and so I think there's some tide that's turning now. I think this is an area that I'm very interested in and I've seen very little research on. Improving physician-patient decision-making around opioid use. And I think this decision-making doesn't happen after the third or fourth prescription. It has to happen before you give the first prescription, in the emergency room, after surgery, in the hospital, in the primary care clinic, for an acute injury or whatever. There needs to be some informed decision-making at that first point, because once they're physiologically dependent, it's almost impossible to give informed consent for ongoing treatment because you need it. And so with the opioids. And I think then having this approach that we do now in primary care clinic was after we start thinking people get into trouble and are dependent, then we give them the narcotic use agreement to sign. And we try to pretend that that's true informed consent. But I think it needs to happen way sooner with the first prescription. I don't know that my colleagues agree with me at all. But anyway, because that would be a lot of patients to really have this discussion with. That's because we prescribe these a lot. Yeah, go for it. Yeah.
Issues of patient satisfaction, like physicians at least feeling like patients want the narcotics and being afraid to say well or not. Did that even at first after that?
Yeah.
Playing a role in why?
I've seen work that's been done on some discrimination in terms of, certain patients don't get as many narcotics as other patients, especially if they're African American, and we don't treat pain as well in African Americans, for example. But I haven't seen much done on patient satisfaction in that early stage. So, and I do feel you need to treat acute pain, and adequately. You need to treat it well. So, yeah, but I haven't seen much done on it. That's an interesting thought. Yeah. Right. There's a lot of pressure. I think doctors do feel a lot of pressure to prescribe. At least that's my anecdotal experience. I think we need to fully inform patients of the risks of overdose to themselves and to other people, including their family members. And that's one of the things that I don't think happened in this case, and doesn't really happen ever in practice, frankly, I don't think, very often. We need to improve the ease of using the prescription drug monitoring programs. That kind of goes with the first one of monitoring patients carefully on treatment. The evidence so far hasn't proven that PDMPs help with mortality, but the PDMPs are not always easy to use, and there's not that much uptake. So I don't know if you had really good penetration of PDMP into practice, whether you'd see a benefit. But the early studies haven't shown much benefit, but I do believe this is a sensible strategy. Yeah.
The electronic health record that I use, when I prescribe something, it notifies me if they've been prescribed something in the same family in the last 3 months. You know how common that is?
In the same family of drugs.
Yes.
Yeah. Yeah. Interesting. Right.
Oh.
Oh. Yeah. I haven't seen that much. No, I have not seen any automatic warnings or anything. I think there's a lot that can be done with informatics in this area that hasn't been explored yet. So the other thing is treatment as prevention. I think this is very important, so I've already made a case for this. Expand the access to evidence-based opioid dependence treatment. Right now, evidence-based opioid dependence treatment is buprenorphine, which is in Suboxone or Subutex, and methadone through approved treatment centers. Buprenorphine is available through primary care, psychiatry, some primary care doctors, a few, psychiatry and treatment centers, and then methadone's really, for addiction, is only available in methadone centers. Then I also think we need to educate drug users and treatment providers in these settings on high-risk times for overdose. You know, people who are actively using drugs do interact with the criminal justice system. I think it's reasonable to inform them that there's a risk when they go in and out of jail and prison, after detox and after hospitalization. And I think we need to look carefully at the transitions that are high risk, like to try to figure out what can be done at those particular transitions to try to reduce the risk. The detox one, to me, is kind of the saddest one because, I mean, they're all sad, but the detox one is also sad because people have really gone in there seeking treatment. But if it's a short-term detox without a bridged pharmacologic treatment afterwards, then it's, you know, very high risk of relapse. And then when they relapse, they overdose. Or they can overdose. So, yeah.
So that if you go back to that last slide,
Yeah.
I think moving to getting to treatment with your patients. So how do you end up determining somebody is now dependent? And you sort of alluded to that a little bit, right? So when you have your I don't know, 50-year-old with chronic neck pain who's now using a lot of narcotics, how do you as the primary care physician say, okay,
right.
enough?
I think when they start, I mean, I'll just tell you personally, and this is not based on really a lot of research, but I think when they start exhibiting aberrant behaviors, you start to get concerned. When it seems like it's starting to affect how they have their social interactions, including with you, you know, they're losing their job, they're starting to have functional problems as a result that may be coming from their dependence. You know, we typically see early refills, multiple requests, kind of some interesting behaviors in the clinic, and then you start getting concerned and you have this gut feeling, this person's running into trouble, and then I think that's an appropriate time to listen to that gut and make a referral for further evaluation and possible treatment. So, yeah. So, yeah.
What about Vivitrol?
Yeah, I didn't talk about Vivitrol. Vivitrol is long-acting naltrexone, and the data, so there's a couple different forms for oral naltrexone is not that great for opioid dependence. So that's why I didn't mention it as an evidence-based treatment. For alcohol dependence, I think it's good, especially Vivitrol. And I think there's more work that needs to be done. Vivitrol, there is some concern that it actually increases the risk of overdose in opioid-dependent individuals. So that's why I just leave it off here, because it's too complicated. So, okay. So I think then the other thing is I think we need to start looking at the home and the family as a site for intervention. So I think families need to be educated about the risks of sharing opioids. I think we need to encourage safe storage of opioids in the home, and I'll talk a little bit more about that, and then safe disposal. So unfortunately, the main way we can dispose of these medications, which are probably in most of our homes in excess, is through these DEA-sponsored drug take-back events. And there's I think there's 5 DEA agents in Colorado, and they were telling me how they personally have to pick up all the meds. They get huge amounts of medications at these drug take-back events. They tons of narcotics, and they have to personally pick them up, lift them into the truck, take them to the offices, unload the truck, these 5 people, and then take them out to the incinerator there's an incinerator in Utah that they take them to. Disposal is a big issue and something that the Colorado Department of Public Health is really working on, trying to figure out how to safely dispose of these medications. And it's not straightforward. Yeah.
You have mentioned more collaboration between primary care physicians and mental health clinicians, like psychologists. As a primary care physician, you have somebody who comes in with cancer and you consult with, refer to an oncologist and an ACL or doing orthopedist. So particularly given the growing concern and new knowledge about the risks with these opioids and all these antidepressants, and primary care physicians are prescribing both.
Yeah.
Do you think it would be appropriate to...
Yeah, I think that's a really good point. There needs to be more communication probably between hospitalists and primary care doctor, ER doctors and primary care doctors, and the mental health specialists, especially around combinations of drugs, because I think we're just starting to understand how risky some of the combinations are. I think so I think that's a really important. I think opening up communication between those subspecialists caring for patients, and I think sometimes that can be very helpful. If I call a mental health doctor and they say, don't give this patient opiates, then I know there's a history there. And that is often confirming my gut feeling that this person's getting into trouble. So I found that incredibly helpful, and getting everyone on the same page around treatment. So I think that's a really good idea. I don't know that there's been any research done on whether those collaborations in managing these particular patients help reduce mortality, but that's a very interesting idea. So, yeah.
What other options either that are present or kind of coming down the beltway are there for non-harmful pain management?
Right. So, yeah. I mean, I'm not up to date on that, but I think there are lots of other strategies we try in primary care. The things we try usually are NSAIDs, ibuprofen, naproxen, Tylenol. We tried physical therapy. We tried back exercise. There's a number of other things that we try muscle relaxants, which also have some dangers associated with them. We sometimes try tricyclic antidepressants, sometimes gabapentin. So there's a number of other strategies we employ, and we try to use those first, but they don't always work. So we do need new strategies, but I don't know what's coming down the pike in terms of current drug development that might be better than what we have.
We've been talking about things like inconsistent insurance.
Yeah.
I think I was thinking, because I don't remember if it was at Boulder where they were looking at non-addictive.
Yeah, pain medicines. Yeah. So back to the family issues. So I think the messages that I've kind of thought of to educate families, but I think more work needs to be done in this, is medications should be secured in the home, just like firearms, to prevent diversion. Don't share your opioids. Don't experiment with non-medical use. Don't self-treat, and try to safely dispose of the medicine. And that I think also maybe people need to understand the dosing is complex. We have a huge variety of potency in some of these pills, from 5 milligram oxycodones and Percocet up to 80 milligram OxyContin. And so that is a huge differential in what's out there. So I think all of those things need to be addressed with patients. These are some safe storage devices, and I actually got this from really the firearm literature and also from methadone clinic, where it's mandated by the state to lock you have to lock your methadone up if you're going to get take-home doses. So everybody comes in with their little box. We give them the methadone, and they cannot be dispensed take-home doses of methadone without having a lockbox. So I think for people on large amounts of chronic opioids, this might also be appropriate, especially if they have teenage kids at home. So the kinds of boxes here, there's combination box, and then there's one that's fingerprint access, and then there's, of course, locked medicine cabinets. And all of them probably have pros and cons. And we're interested in exploring some of those more in terms of what patients really want and can use in further research. So some of the research gaps for safe home storage of opioids is who to target, all opioid users, people who get a dose in the emergency room, or people only on high dose. I don't think we know that. What messages do we give to the patients to maximize adherence with these use of these boxes? What kinds of devices do they want? What kinds of features? Should insurance pay for these boxes? And how should they be distributed at the pharmacy, in the clinic? We don't really know those things. And then are they effective at preventing diversion or overdose? So there's a lot of questions to be answered, and this is one area of research that I've been interested in getting funded. So now I'm going to turn to Narcan or Naloxone, which some of you have used on patients. This is a effective opioid antidote. It's been approved since 1971 via intramuscular and intravenous routes. It reverses all signs of opioid intoxication, especially the respiratory depression. It takes less than 2 minutes to act. It lasts about 20 to 90 minutes. That does mean that sometimes if someone's on a long-acting opioid, they need another dose. This is one consideration to keep in mind. And there's no abuse potential. In fact, people hate Narcan. They don't want to be Narcan because they wake up and they're in withdrawal often if they get too much. So now the rationale for naloxone for take-home use is to prevent deaths and medical complications of overdose through earlier treatment. This is especially true for rural areas or places where people may not call 911 or places where it takes a while for the paramedics to get there. And usually it's distributed with education and training, including how to identify an overdose, what is an overdose, administer naloxone, call 911, provide rescue breathing. This is not CPR that's required in these events. It's actually rescue breathing. And then stay with the victim. Don't abandon them. And I'll talk a little bit more about that. This is an intranasal kit. This is what I was saying is not FDA approved yet, but this is a kit that many community programs are starting to use. It's really nice because you avoid the use of needles in people who may have a history of opioid use via injection, which avoids some risk of bloodborne infections. And so people can just basically give a dose in either nostril. And it is effective. It's used by paramedics, for example, in Denver. So in a MMWR article that was published last year, Eliza Wheeler in San Francisco, who runs one of these programs, did a survey of other programs and basically found there's 188 naloxone distributing programs in the U.S. There's 15 states with these programs. They've trained over 50,000 people and had reports of over 10,000 overdose reversals. There's been various evaluations in heroin users predominantly that have dated since the 1990s that show these programs are feasible. They're associated with increased knowledge and skills in dealing with an overdose among drug users. There's no increase in use apparently as a result of giving naloxone, so people don't go out and start using more. There's increased drug treatment admissions. There's some anecdotal, smaller evaluative studies that have suggested that people may actually, who get trained, may be more likely to enter drug treatment. And there's some thought that being trained to use naloxone and save a life has some improvements in people's sense of self-worth and self-efficacy that might actually lead them to seek treatment. So there's some interesting psychosocial effects of this intervention that may be beneficial. In a very recent study published in the British Medical Journal, there's been a reduction in overdose fatalities in communities with high penetration of naloxone programs in Massachusetts. So they compared communities where they just had either no programs or it didn't reach that many people to programs with a lot of penetration, and that showed some reductions in mortalities in the towns and communities where there was high penetration. And then another recent study just published a month or two ago shows that it's also cost-effective in modeling for heroin users. So this is a very cost-effective intervention. We don't know about pharmaceutical opioid users because that's a much bigger population. But for heroin users, it's clearly cost-effective. So this is some of our study work with Karen Corsi that we did at Project Safe, looking at Denver former inmates. And we asked them, have you ever witnessed a heroin overdose? Whether the person lived or not, and 46% of them said, yes, I'd witnessed an overdose, so a very high-risk group. at the last witnessed overdose, did somebody call 911? We didn't ask, did you call 911? Did someone call 911? And only 54% of them said somebody called 911, which means the rest were abandoned. So, or maybe the person got better. They might have gotten better. But this is one of the problems that we're trying to address with community distribution of naloxone, because if people have warrants or they gave them the opiates, say you gave your friend some opiates, that's illegal. You could get arrested. You might have contributed to their overdose. That's, pretty significant crime. People are not going to stick around for the paramedics and the police to come. So then we also asked them, are you willing to receive training to use Narcan for a witnessed overdose? They said overwhelmingly yes. Are they willing to give it? Yes. Should people get it after leaving jails and prison? And predominantly they said yes. So there was a very strong willingness and acceptability. And this is an issue for the FDA because naloxone is used by a bystander and not necessarily the person to whom it's prescribed. There are some interesting FDA technicalities, and they do need to know that it's acceptable to the people who are most likely to have it used on them. So that's part of why we were looking at these particular questions.
Ingrid, I don't understand the second line. Could you just clarify?
So are you willing to actually give somebody Narcan? Are you willing to give it to them? Are you willing to administer it to them if they overdose when you're with them? Okay, so some additional consideration. 911 Good Samaritan laws, I think we had one passed last year or the year before, are very helpful. They give immunity to bystanders who witness an overdose and call emergency medical services. That's extremely helpful for this particular problem. Naloxone laws provide some immunity for prescribers who give it, and then it's ultimately used in this uncontrolled setting in the field, and also for the bystander who administers it to somebody else. So it basically helps to deal with this fact that these medications are not always given by the person to the person for whom they're prescribed. So we have one being considered now in Colorado, one of these laws, and they've been uptaken by a lot of states already, and more to come. So that's very encouraging. Intranasal delivery is not yet FDA approved, but it's widely used, as I mentioned. Over-the-counter naloxone is being considered. I mean, it's not going to be anything that happens in the next 5 years, but FDA is talking about it, is interested in data to support OTC naloxone. There's a lot of issues with how much people understand in just the little label that's put with an OTC drug, and that's the biggest consideration from the FDA's perspective is, can people understand how to use it if they just buy it off the shelf? And then there's wide endorsement of naloxone by federal agencies. They've really gone way ahead of the states in terms of taking this up, and ahead of physicians who are generally not as avid uptakers of this. So even the drug czar and NIDA, the office of the White House Office of Drug Control Strategy, they've all been very encouraging, and SAMHSA, very encouraging of naloxone.
Is it obvious to folks who's overdosing what an overdose looks like? And their use of naloxone?
I think there's more work that could be done on. I think it is. I think it is generally in these groups that are predominantly targeted for these interventions up until now, which have been heroin users. They are very familiar with overdoses. They've seen them. They know what they look like and stuff. So I think it is. When we start getting into pharmaceutical opioid users, I think there's going to be some additional, or pain patients, I think there's going to be more work that has to be done to really understand if people can get it, like what is an overdose. So, but the downside of giving Narcan is not that big as long as you call 911 quickly. I think if it causes a delay in getting emergency medical services in somebody who might have another condition, then there may be a little problem. But I think that's unusual.
So right now, can a physician prescribe naloxone to a person?
Yes.
And
And
take it
Yep.
and have it at their house?
yes, you can. There's no reason you can't do it. But
Does that
it's
happen? Do people ask?
but people don't do it yet much. So usually in these programs they do. Yeah.
Hi, so do you think that some people, if you give some people this naloxone kit, some people will think it's maybe a get out of jail free card, and so they'll give themselves higher doses
doses, yeah.
of their heroin. Think, oh, I've got this naloxone, it's cool, I can just take it if I do overdose.
That's not been the experience of these programs and the small evaluations. I think there's more work that has to be done in that, but that's not been the experience. So the small evaluations have suggested that people don't use more just because they have the naloxone.
The individual who's being prescribed the naloxone is the individual who's also being prescribed the opioids.
If we were to implement co-prescribing, which is what this model would look like, yes, we would do that.
So very clearly articulated the education.
Yes.
But you're educating the person that's going to need it. So are you asking them to bring a family member?
So that's exactly what we would have to do. We'd have to have them bring a family member and train the family member about it as well. So that would be the idea. So I can imagine group type sessions, individual sessions. We still need to determine where would this take place. Is it the pharmacist that educate them, the primary care doctor, how verbal, video, DVD, web-based. There's any number of options for those, and that's all stuff that there are some DVDs out there. There's some websites that explore this and stuff that people can get this information from. Okay, so I'm going to show a video of this naloxone thing.
Turn both different lights.
Terry Cole carries a drug overdose with this reversal kit with her where she goes. That's because she didn't have it when she needed it most in 2009, when her son Timothy died from a heroin overdose in her home.
To live with that is something that's unbearable, that I would never want anybody else to live with.
Similar to the rest of the country, the number of overdoses here on Long Island has been steadily growing for years. Dr. Scott Coyne believes a special nasal spray can reverse the trend.
The heroin problem is pervasive. It's pervading all different socioeconomic statuses, from the upper class, the middle class, the lower class. It's in all regions of the county.
Under a pilot program overseen by Coyne, a handful of police officers have been carrying intranasal Narcan since the beginning of August. Since then, police have saved 15 people. Officer Michael Alfieri recently administered the nasal spray while on patrol.
A male and female jumped out in front of my police car, flagged me down, and they said that their friend was turning blue in the back of their car. And I looked over, and there was a female slumped over in the back seat.
So he sprayed the medicine into her nostrils. It absorbed into the membrane of her nose.
She opened her eyes, and she started breathing on her own again. She regained her color, and her heart rate rose, and she was able to speak, and she didn't want to go to the hospital.
Intranasal Narcan is a trademarked type of the medication Naloxone. Fatal overdoses happen when a drug like heroin or oxycodone shuts down the mechanism in the brain that controls breathing. Within minutes of being administered, Naloxone removes the opiate molecules from the brainstem. The person starts breathing again and wakes up. Despite some high-profile arrests of heroin dealers here, the drug continues to be widely available.
Good morning. My name is Danielle. I am a heroin addict in recovery. I'm about 18 months clean.
Danielle Pinto says she had a good job as a project manager when she got hooked on prescription painkillers. That led to heroin.
It brought me to some really horrible places, things I never thought I'd have to do to get the next one.
Pinto went to rehab and is now a substance abuse counselor. Coyne is hoping the nasal spray will give others the same chance.
Society admits that there is a problem, and this is a medical treatment, a medical remedy.
Terry Kroll doesn't like to think, what if she had Narcan when she found her son had overdosed. Now she carries the overdose reversal kit everywhere in case she comes across someone ODing in a parking lot or a grocery store, and she can save them.
It's a silent war that's being fought by, unfortunately, our children. And some of us don't even know it. I didn't know. I had no idea my son was using street drugs. None.
In Suffolk County, police are the first on the scene of 911 calls almost all the time before an ambulance arrives. Coyne hopes that by next year, every police officer in Suffolk County will have the nasal spray, standard issue, along with a gun and a radio. Ted Shapley, Associated Press, Long Island, New York.
That literally happened, that a police officer can have it when it's a prescription that's not being prescribed for a specific person.
So this is a special program that was started I think they said Long Island, and it's kind of a model program where they are giving it to, they're training police officers to use it and to carry it with them. So I don't know what their specific state laws are, but they're doing it. So let me hold questions for 1 minute so I can just finish a couple things, and then we'll go back to questions because I'm sure there's some others. So back to the case. So let's see. I think that case that I started with at the very beginning with the mother and her daughter and the grandchild really reflects that users of pharmaceutical opioids are not necessarily the intended recipients. So when you prescribe it, it's not necessarily going to go to that person. Polypharmacy can contribute to the risk. As you saw, she was on amitriptyline and she had amitriptyline and opioid on board, which is not an uncommon combination. I think healthcare providers need to better counsel patients about the risks of opioids to themselves and their family members. Safe storage may have been beneficial in her case, if nothing else, just to remind her that she shouldn't share with her daughter, or remind her daughter that she shouldn't take her mother's medication. And then naloxone could have been tried. That's not grammatical, but naloxone could have been helpful before the paramedics arrived. I don't know that it would have been. It might have been too late anyway, but it's possible that it was. I don't know how long it took for the paramedics to get in there in that situation. So in conclusion, opioid overdose is really reaching many sectors of our population. I think intuitive strategies may not be safe. Some intuitive strategies, like put them in detox or cut them off the pills or whatever, may not actually work that well, because we see people then just getting medications from some other source or potentially relapsing after lower tolerance. And I think some of the emerging strategies that I've gone over is improved prescription and decision making, improved storage, and then widened access to naloxone. And I just put a few additional resources. One of them is Addiction Research and Treatment Services, and we have Libby here who runs that program, and we provide a lot of treatment around Colorado, as well as our local naloxone program is with the Harm Reduction Action Center in Denver, and they provide naloxone to heroin users. They've maybe distributed 50 or 60 doses so far, so it's a small program, but hopefully will be increasing. And then these are some colleagues who've really helped me in this particular line of research. So, yeah, so I'll take questions now. Yeah.
One thing particularly for those of us who aren't clinicians, could you explain a little bit about the role of alcohol in interacting with these medications and how big an issue that is?
I think it's a pretty big issue. I'm not a toxicologist. Is there anyone who can speak to that?
I mean, alcohol is very other substances that have been thrown together a lot. It's something to consider. I'm not aware of people looking at alcoholism, but maybe alcohol, psychiatric disorders,
Well, and part of what made me think that was when you were showing the data on like the first week after release from prison, and I just wondered, is that a time when people are engaging in a lot of drinking, and that the risk is in part associated with the alcohol use?
Yeah, that's a good point. Yeah.
In the social environment.
I haven't looked at that specifically in our data, but alcohol is among the multiple causes of death, so those were opioid-related plus alcohol, but I haven't quantified exactly to what extent that's the case. But yeah, there's this anecdotal descriptions. People go out and they party after they get out, and so they, yeah.
And other times of transition.
Oh, yes, that could be true for the other times as well. So.
alcohol is interesting, hard to check.
Other questions? Yeah.
Do you think just educating, people, for example, coming out of jail or something like that, about why this is a risky time for overdose, and that if you're going to return to using, to not return to the level that you were previously using, or other strategies?
Yeah.
Just education?
I think education will be beneficial. So we did qualitative interviews with people recently released from prison, and there were a few that said, the first time I OD'd, I ended up in the intensive care unit, and I didn't know if you do too much, you can overdose. So that's kind of the language they use. And then I learned that after that first ICU, that time I spent in the ICU. And so the next time I got out, I was more careful, that kind of thing. So, so I think some preemptive education would be helpful.
What is the shelf life for the DSM kits? Are they good for years?
The naloxone itself, I'm not sure. It's not indefinite. I'm not sure if it's, I don't know. But it's not indefinite. There is a shelf life.
And so would you tell substance abuse providers, for example, who are maybe prescribing Naloxone, but the client wants to try to withdraw or something like that, to then just go ahead and start giving out prescribing these kits for those kinds of high-risk patients? Or what would you tell a family member who has a child that is using heroin, but they haven't been able to get them into treatment yet? Or,
I mean, I would like to see those high-risk people, opioid dependent, in and out of treatment, things like that, given education, structured education, and their families educated, as well as having, I think it would be better for them to have naloxone around. But again, what level of penetration do we need? Does it need to be in the social networks and the family networks? Where it needs to go is unclear.
And right now, you can't really prescribe it?
You can. I can write a prescription to you. I mean, to somebody who has a risk, rather. No, that's the tricky thing is these programs, the community-based programs, the way they do it is they buy all the supplies, they make the kits there, they make them into they put them in little packages, and they put in some information in with it, and they make a kit. And so it would require some coordination. That's the tricky thing is you have to coordinate with pharmacy to get the intranasal kit. So I could prescribe it, but I'd have to get a pharmacy to put the kit together. Or to give everybody all the pieces of the kit, because I have to write for the kit. There's really 3. You need the syringe and 2 other pieces of the kit, plus the naloxone itself.
So a treatment program like ARTS could try
Purchase.
to implement by doing the same kind of thing, purchasing them mass lines, putting together the kits,
Yes.
on hand to distribute, or something like that.
You could either do it yourself or work with a pharmacy to try to see if they're willing to help do it. Both models have been used. So, okay, great. Thank you so much.